AI for skin cancer detection.
So I'm the Chief Medical Officer and CEO at Check for Cancer. We're a patient-focused and evidence-based early cancer detection company. But today I'm going to focus on how we've developed an AI model to help with skin lesion classification. So I first developed a decision aid in 2010. This is Predict. This is a decision aid that helps clinicians decide about the best treatment after breast cancer surgery. We're now up to version 3. It's now used all over the world, but the initial model was built using data from only 5,500 patients. So the message I want to get across is it's not just about the quantity of data you use for AI or decision aids, it's the quality of the data. In the last 12 months, there have been 2 landmark papers showing how AI can improve the breast cancer detection rate during screening mammography. And both of these studies have shown that you can increase that by up to 13%. So good evidence base. It's no surprise that AI has been effective here because breast screening programs have really strong quality assurance. So the mammograms are all high quality. So again, the success has been driven by high quality data. And I think by using AI in cancer pathways, we can speed up many of the pitfalls that slow down cancer screening or diagnostic pathways. There we are. At Check for Cancer, we run a very successful teledermatology pathway for people with symptoms for 1 or more worrying lesions. The symptoms are up in the pink box in the left-hand corner. We can see these patients really quickly throughout a UK network of nurse-led clinics where they take the history, take really high-quality images, and they're uploaded for telemedicine reporting. Out of everybody who enters this pathway, we reassure about 80% immediately they require no further investigation. Of the remaining patients that go on to face-to-face assessment, we biopsy about 10% and about 4% are diagnosed with cancer. Of all the melanomas diagnosed in this pathway, 96% are stage 1 or 2, so that's early stage, where the 5-year survival is at least 85%. So this is a really successful pathway, but how do we scale it up? Well, the problem is we have a perfect storm in skin cancer at the moment. The global incidence is rising, and we have international shortages of dermatologists, of skin cancer nurses, and of telemedicine reporters. But what we can do is we can use all the data that we have gathered in this pathway to build an AI model. So this is our proposed AI model. We can have images captured using an app, either in our nurse-led clinics or at home. These are then uploaded to help our healthcare professional, who will have access to the AI model as a decision aid. So effectively, we're going to help the next generation of telemedicine reporters get up to the level of experience with the doctors that we've been working with to now. In total, we used about just over 70,000 images from just under 20,000 patients. And this was a knowledge transfer partnership with the University of Essex, supported by funding from Innovate UK. This is the AI model architecture, and we use 3 different efficient net models with input both from skin images and also all the clinical information that we have on each patient, and I'll tell you a bit more about that shortly. And what this model does is it classifies each lesion into reassure or bring back for face-to-face assessment and possible biopsy. So how did we do? Well, the first thing we did was we used machine learning to look at these 22 pieces of clinical information, and we brought it down to these are the top 7. So these are the 7 most important clinical features, not just for melanoma. This is a pathway for potential skin types, cancer of any skin type. And what we've done is we've applied a proportional weighting to come up with our Check for Cancer risk score. And we published that in Nature Scientific Reports in September of this year. So let's look at the actual accuracy of the model. So if you look at column 1 and column 2, column 1 is the sensitivity for skin cancer detection using just the images alone. Column 2 is the images plus our C4C risk score. Now you can see, apart from, if you ignore the bottom row at the moment, if you look at all the numbers, they're all 99% or 100%. So we know that images are really good at detecting skin cancer. But what the clinical information does is it increases the benign sensitivity, which is the specificity, from 63% up to 74%. And that is really, really important because it means we're not bringing back too many patients to the face-to-face assessment to diagnose these cancers. So how are we doing with our competitors? Skin Analytics are a company that offer an AI-assisted assessment for patients, and they've been working a lot in the NHS, and they make their results publicly available from their website. So you can see if we compare ourselves with them at the moment, we're 2 or 3% higher at the moment. But perhaps the most important benchmarking is against human reporting. And we've used 2 Cochrane databases to look at their meta-analysis to find out just how good human reporting is, because this is the standard against what we should be comparing AI that's being used for healthcare. So what they say is that when they look at all the studies, they fix their specificity at 80%, and the average for a face-to-face assessment using dermoscopy is a 96% cancer detection rate. We can actually toggle our sensitivity and specificity, and if we fix our specificity, this is column 3 at the bottom at 80%, then our skin cancer detection rate is 98%. So we're certainly as good as human reporting, and it looks from these data like we're better. So we foresee the model being used firstly as a decision aid, so that the final decision is made by the healthcare professional who has access to the output from the AI model to help classify these lesions to suspicious or not. It can also, however, be used to partly automate this pathway. And so in this diagram, you see that before the human report happens at all the lesions go through the AI model, and those that are suspicious could go straight to face-to-face assessment. We're also working on a second model at present to see whether we can accurately identify a group of the non-suspicious group so that they could be reassured without healthcare professional reporting. So all the success that we've had to date has been driven by high-quality data, not just images, but clinical data as well. And as I've said, our overall sensitivity is at least as good, if not better, than the Cochrane database meta-analysis of human reporting. The metadata input to this model is significant, and it's lacking in most of the AI models for skin cancer classification that exist at present. All the way through, we've tried to build our evidence base. We're an evidence-based company. We've presented the data at scientific meetings, ESO and the British Association of Dermatologists. We presented at the IEEE International Conference on Digital Health in Shenzhen in China in April of this year. And as I said, we just published the metadata paper in Nature Scientific Reports. We've just submitted the actual fused model using images and metadata to Nature Communications, and we're hoping for a positive result. Looking at the markets, we plan to use this with the existing private medical insurers that we work with, and we think this will give us leverage to go and attract new private medical insurers to work with us. We're also looking forward to helping the NHS by trying to improve the time to diagnosis and treatment, which unfortunately is long for patients. And in the UK, patients with a suspected basal cell carcinoma are not eligible for urgent referral. And we're also looking for partners who can help us internationalise this beyond the UK. Next steps, apart from the fact we're trying to go through the whole medical regulation process in the UK, the EU and the USA, we have a prospective audit comparing the AI model decision with our human reporting. We're expanding our work in explainability. It's really important that the healthcare professional understands the output of the AI model. We've got a further grant to look at our model performance in darker skin tones. We've already been talking about equity. I think it's really important that we do that. And as I say, we're looking for international partners. And finally, we want to link this up with our skin cancer app, which can help patients take really high quality images at home. I think if we manage to do all of this, it will be not just good for patients, it will be good for clinicians, and it will give us an AI model that is not just sustainable, but equitable, and I think that's really important. Finally, I'd just like to thank all the project team, all the scientists that worked on this. It really is a fantastic example of what you can achieve by a collaboration between industry and academia. Thank you very much.